both come from the payer side. I now work for a company called Genesis Healthcare. You've probably heard about us once or twice, and run our long-term care ACO or LTC ACO, another original name in the industry. So I spent almost 20 years in the Medicare Advantage business, growing a business with about 175,000 lives before selling it. Had a couple thousand iSNP lives, so definitely know the market. And I'm excited to be here and talk about population health in a long-term care setting with René, and different ways that we both are kind of addressing the market in a very similar way, but with different financing platforms. So René, do you?
René Lerer with Longevity Health Plan. I've been with the plan for about a year. Actually, years ago, started as a practicing physician, internal medicine in Connecticut. Now live in Florida. Prior to joining Longevity, a little less than a year ago, I've been in the managed care world like Jason for many years. I was president of Florida Blue Cross. So that was the largest plan in Florida, about 4.5 million lives, about 19 billion in revenue. And before that, I was CEO of a company called Magellan Health, which was the largest behavioral health company in the country, and then got into pharmacy and radiology. And we took that from bankruptcy back onto NASDAQ and turned it into today an $8 billion company. So this is new for me. It's startup. I understand the managed business, learning the nursing home business with a strong team behind us. We've been around for a little over a year, and we're now probably expect to be the second or third largest iSNP by the end of the year. We're almost, within a year, almost at 2,000 members in a transparent JV model, and trying to meet the expectations of our partners and owners. Since some of them in the room, I want to make sure I make them happy and life is good. So that's our background.
Good. So René, maybe I'll kick it off and punt it back to you, but just,
Sure.
Coming from different parts of the payer industry, maybe what attracted you to the iSNP business, and what do you see as the value proposition?
Sure.
Of the iSNP business?
So, it's quite interesting, having run many large health plans. I was at Prudential before that. Medicare Advantage was always quite interesting. We had several 100,000 Medicare Advantage lives in Florida, and it was always a challenge, because in traditional MA, you don't know where the patients are. The PCPs, the docs, may or may not be engaged. You have difficulty scoring them. And I learned about the iSNP world a couple of years ago, doing some work for private equity, and realized this is a much better, much more effective model for patients who are the neediest, for the senior populations who are, in our models, both long-term residents who really need to get better care and better management. The advantage here versus an MA plan, we knew where the patients were all the time. We could code them, which we couldn't do in a traditional MA environment because you couldn't find them. You could manage them because you knew where we were. So everything that we saw in a traditional MA plan could be done better and more effectively. And it was the classic example in a health plan, not just MA, of doing doing well and doing good, where you can do the right thing for the patient, for the residents, and also be successful in a business. And it was quite unique. There are very few places in healthcare where you can do both of those things. So it was quite interesting and quite attractive. And as we developed, and we'll talk about in a little bit, the longevity model, it really was meant to be a provider-sponsored plan with deep partnerships with all of our owners. And that combination in doing the right thing made it actually a fascinating opportunity. Doesn't traditionally exist in the traditional MA world. I'm assuming you found similar experience.
Yeah, so coming out of the MA world, and I've known George Hager for years. He asked me to come on board almost 6 years ago now to help move the company from a fee-for-service environment to a value-based environment. So the first thing we did was got in a bundled payment program, did extremely well there. Was very disappointed that went away, but he had continually challenged me and kept pushing the iSNP, and I said, well, we're a large public company with no money. That's pretty hard to do, especially when you're in 25 states. So since 2010, I'd been researching the Medicare Shared Savings Program, which came out of the Affordable Care Act, and which is at risk, of course, but it's really not, the value-based programs really aren't the target of the lawsuits, it's the individual mandates. So you feel comfortable there, but I too believe that the advantage is that we know who the patients are, they're receiving care when a doctor writes an order for them, and unlike a typical Medicare Advantage plan, or quite frankly, a typical ACO, you're able to control the care. So we've been in the Medicare Shared Savings Program now for 4 years. The first year we produced savings, but not enough to share them with the federal government. The second year we incurred a loss, but we weren't at risk, and it was due to maturations of CMS. The third year we received a check, and 2019 being our fourth year, we're projecting some nice savings. And you know, what we've done with the long-term care ACO is we've now taken it to third parties, non-Genesis operators, to do very identical things that René and others are doing, and that's becoming a partner with the facilities, a partner with the physicians who create the membership, if you will, in a program, and really improve the quality of life for the folks living in those facilities, and quite frankly, a value add to the facilities themselves. And I think you probably see the same thing with your health plan model.
So, you know, the models are actually quite interesting. You could argue that we compete with each other, but in many ways we really don't compete with each other. It's a niche play on honestly both sides, but the good thing about the niche play is it's not overlapping. So that you can look at the long-term care population in a building, and between the two programs, satisfy the needs of the residents in those buildings with either one or the other. There are advantages and disadvantages to one over the other, there always are, and we decided to take a different path. Obviously, the ACO is a fee-for-service healthcare. It's fee-for-service traditional Medicare where there's incentives, and we're a managed care plan. It's different. There are nuances that are the same, and not everybody wants to be in managed care, and not every building wants to be in managed care. But our view, and my personal view, having done this for now 35 years, is the world is moving to value-based care. We may like it, we may not like it, but the world is going to move to managed-based care, and CMS is going to mandate it more and more. 3 years ago, CMS came out and said 50% of all contracts will be value-based. The good news, both of us can describe ourselves as value-based. The difference was we're an insurance plan. So the difference on our side is members enroll. Every member who's in an ISNP knows they're in the ISNP. In the ACO, it's a bit different. The value propositions, the goals are similar, but we looked at this space, and we're not the biggest out there. Obviously, there are players that are much, much bigger than we are. We have big aspirations because that's what we do, but with a very different model. And the model that we had was a transparent model working with nursing homes, nursing home owners in true partnership. We're in 5 states today. Again, it's much harder for us than an ACO to expand. We have to get insurance licenses. We have to have contracts with CMS. We have to put up risk-based capital. You have to have a minimum net worth. You have to build a network. We are a full-service Medicare Advantage plan. And so we have a contract with CMS who pays us a premium. But in each of our states, and we're now in 5 states and expanding 2 to 3 states a year. Today we're in New York, Illinois, New Jersey, Florida, and Oklahoma. In each of those states, we find partners. And the plan is owned 50-50, generally by us, by our investors, and by the nursing home owners. And so there were partners. Everything is transparent. Every penny that comes into the plan, every penny that goes out of the plan is purely visible to every partner that we have, which is unique. Most people are not doing that. Every time, if someone is doing well, everyone collectively does well. There is no, I'm a big fan of win-win. I'm not a fan of win-lose, where one party wins and the other loses. So it's truly a partnership and truly a sharing. And probably the biggest difference is because we're an insurance company, we have a lot more requirements. makes it a lot harder, requires a lot more investment. But on the other hand, we create a different, I believe, and Jason will explain it, a different experience for the resident. One, because number one, we offer different benefits. Fee-for-service medicine doesn't offer supplemental benefits. You're not allowed. We do. So we can offer transportation, we can offer dental, we can offer music therapy, we can offer companion services. We can identify the needs of the members in our buildings and create specific plan designs to meet their needs. In fact, as you know, in MA today, we have to submit bids. So our bid is due in June, not just us, any MA plan in the country, and you have to submit a plan of benefits and submit a detailed actuarial bid. We are in the process now of working with each of our current state owners and the states that we'll be going into in 2021 saying, what's important to you? Some states have told us we need better transportation benefits. One state came back and said they would like to get hairdresser appointments for the people, for the women in their plan, because it's very important to them. And the buildings pay for it anyway. So we can design and go out and meet the customized needs of our members. And then we have full-time, dedicated NPs who sit in the building, who coordinate with the residents, coordinate with the PCPs, coordinate with the staff, coordinate with the family, and it's the same person. That NP, generally a woman, is there full-time. She's not on fee-for-service, she's salaried, and her job is to get to know socially, medically, clinically, the patients in that building who join us, and to take care of them in conjunction with the PCP. So it's a very patient-centric model. And above all, we're an insurance company to do all these things. But number one, and maybe because of my background, we're first and foremost a clinical company. I'm a physician. The clinical leads drive this company. And the goal is to improve the quality of care for patients in this situation. And honestly, the most part, average life expectancy of the patients who enter the plan, probably 3 years. In some places less. They're much older, have many more comorbid conditions, they're sicker, and the goal is to make their life as higher quality as you can, treating them in place, keeping them out of the hospital, providing the necessary social, clinical services for them to create the best possible experience that they can have given where they are in life.
Yeah,
good?
I mean, that was good. That's I think we have very similar goals. Like you, we partner with our providers, both the physicians and the SNFs. You are correct. I mean, we're in 25 states. Next year we'll be in 6 states, and we have very little regulatory capital that's required. And for all the reasons, as you were listing off all the reasons,
That's why you didn't do it.
that it made me remember why I didn't want to be an ISNP. You know, that said, and to Renee's point, this isn't a either or better than. These are really two complementary programs. And as I think about, you know, our growth, the ACO's growth, you know, I too am looking for provider partners who have made a decision to care in place. And by making that decision, they've done the financial calculus to say, you know, they may lose some money on all the admissions, the readmissions, the skilling, but there's money to be made on the back end. And while we have different financing mechanisms, I think we have very similar objectives. As René indicated, under Medicare, you can't offer enhanced benefits. So you don't have the ability to offer enhanced benefits. That may change in the coming years. But that said, these programs work very well together. I've got a friend in the back from Optum, and we happen to be, Genesis is Optum's largest client nationwide, and we've been fully transparent with them since day one what our intention was. And so we've got 4,000 ISNP members in the Optum program that sit alongside our 6,000 plus ACO members within Genesis. So we've been able to leverage their capabilities. We too have nurse practitioners working with our physicians. in the Genesis facilities as we go to third parties. We won't be employing the nurse practitioners, but we'll be using nurse practitioners to work with, to work in these facilities, and using a very similar clinical template. But really making sure that we partner with facilities that understand that caring in place, it's much better for the resident, and it's much better for the facility, and it's much better for the family. So I find these to be very complementary. I guess if you asked me 3 or 4 years ago, I don't think I responded that way.
3 or 4 months? No.
Sure. But in today's world, people have to, the industry is waking up to the fact that things have got to change. And whether you want change to be that you want to get your hands on the premium dollar to control care, or whether you're not in a position to take on the risk and control that premium dollar, or the market's already forcing you to care for people in your facility. The hospitals lose money on Medicare patients. They don't want to see them come back. So the market's already telling you to take better care of your residents. And to the extent that you do, you're really banking on the fact that you'll maintain your preferred provider status, and that you'll continue to get distribution from the hospital. But that's a bet that you're making. I think in this new value-based world, we're creating value up and down the distribution stream, and it can get monetized. So I think both programs create a new financing mechanism for the industry.
I think what's interesting is we do similar things. The mechanisms are a bit different. The financing's a bit different. The cash flow's a bit different. But the underlying similarity is to get cooperation from the buildings we work in to understand the changes that are happening. And I think that's probably both our biggest challenges, which is the way that building operators have historically been incented is countercultural to what value-based care is about. Value-based care, so buildings historically have operated, the way they maximized their income or generated their income was to provide services. The value-based world, and having, again, lived in this in the Medicare world for years and years, the value-based world is you create value for the building by taking care of the patient in totality. So whether it's in the ACO, or whether it's in the ISNP, the incentives are based on total medical costs, which means in an ISNP world or in an ACO world, it's the same. Someone goes to the hospital, that's deducted from your premium or from your ability to bonus. So when we go into buildings and the administrator is incented by maximizing their Part A days, that's countercultural to where the world is going. And that requires a very different change in thought. When they're looking, we have examples, and I'm sure Jason does as well, of services that have been provided in a building by outside physicians, totally inappropriate, totally clinically not making sense, but the buildings didn't intervene because it didn't impact their financials. And today it does. Today it impacts their ability to earn a bonus or earn a gain share. And so what we're finding in the buildings that are engaged, they're much more involved with the total care of that patient. Not just what happens in the building, but what the specialists are doing, what drugs they're taking, what referrals they're happening, which is the essence of value-based care. It's the management of the total clinical care and the total cost of the patient. And that's in common to both programs.
So when you, René, so we're both going after the same markets, either jointly or by ourselves or whatever. But if you come across, what do you do when you come across a provider that is looking to maximize their Medicare A days?
So, we've done a couple of things that are a bit different, but when we go to a building and we see their admissions, and Medicare and insurance talk about admissions per 1,000. That's the metric that's used. So for every 1,000 residents, the number of admissions that are seen. So if you, for example, the target is a little bit, this is a little different from both of our businesses, but target's 250 admissions per 1,000 means if you have 100 patients in the plan, there should be 25 admissions for the year, 2 times 2 patients a month. That would be 240 admits per 1,000. We've seen buildings with 100 patients have 10, 20, 30 admissions a month. They just constantly send people to the hospital. Unless they can mentally change how they think about it, it's not a building we could succeed in. It's not a building that should be part of an ISNP, and it's not a building that's over time gonna be successful, because the hospitals will give them a hard time, Medicare will give them a hard time, but it's an evolution. So in a building like that, we see it a lot in buildings with lots of mental health patients, and in different parts of the country, many of the SNFs are filling with mental health patients. Very different protocol, very different environment. Most of the clinical people in those buildings cannot manage these patients. Having run the largest behavioral health company in the country, where at one point we had 60 million covered lives at Magellan, it was very clear that traditional RNs could not manage that population. They didn't know what questions to ask. They didn't know the answers. When we tried to outsource this to some of our customers, we worked with all the big plans in the country. The nurses refused to ask the key question, which is, are you suicidal? Because they didn't know what to do if the person said yes. And so they'd rather not ask. And we're now seeing that same thing in the SNFs, where more and more beds in parts of the country are being filled by mental health, and they don't know how to manage the patients. The needs are different, and someone gets rambunctious, they send them to the hospital. There needs to be a change in the management and change in the culture in those buildings. And if we have a building like that, it's just not a good candidate for us or for you.
Yeah, no, we do the same thing, and that's part of the message that I wanted to get across. We see it. We won't go into a building that's not well managed. We won't go into buildings where physicians are looking to do nothing but just bill and not take care of patients. Some of that's easier to change than other pieces. So, besides using a nurse practitioner, trying to incent the physicians, we've also gone to using telehealth as kind of our backup plan. Really not a backup plan, an enhancement to the plan, because it's so much easier to send someone out than it is to keep someone in. And if they can get the reassurance of a doctor who is used to being woken up in the middle of the night to get on the telemedicine platform and examine the patient virtually, you do get better outcomes.
But the interesting thing we've seen in buildings, they have emergency drug boxes. Makes sense. We've seen buildings where it's 10 o'clock at night and the person needs something and they can't open it because there's no pharmacist there or there's no RN there. So they have no access. Or treating in place may mean starting an IV or giving some antibiotic, and they go, there's no nurse here at night, so we can't do it. Buildings like that are not compatible with treatment in place. We've got to work with them to make sure they have the capabilities on site. The reality is the patients who are in nursing homes today, 10 years ago, were in hospitals. And so the acuity of the nursing home patient, and you guys know better than I do, has gotten much higher. But not all of the buildings have moved to the point that they can treat that level of acuity, particularly in the middle of the night or the middle of the weekend. And that's the challenge. So when we go into a building, we do a clinical assessment first to make sure they have the capability to meet the needs of the residents, whether it's 1 o'clock on a Monday in the afternoon or 3 in the morning on a Saturday. And it varies. And so we train those buildings, we train their staff, we go in with our teams to get them to understand what they really need to manage these patients the way they need to be managed in place. And I'm sure you see the same thing.
Absolutely. It's a hard paradigm to change. And, whether it's the tools of telemedicine or the data that we provide them, it's a tough paradigm to change altogether. But I think, the purpose of this discussion, one of the purposes is the aligning of the incentives. And once you put that in place, and you've got the attention of ownership, you've got the attention of leadership of the organization, you've got another mechanism to which to create that change.
Why don't you, we can, but why don't you describe the incentives in an ACO versus in our environment? They're similar, but a little bit different in ways.
Sure. So, you're obviously working under capitation. You're providing a share to your providers in the ACO. Everything's getting billed through the Medicare system. Everything gets reconciled the following year. And we're sharing in 25% to the facility and 25% to the physician. So again, a 50-50 share, just
Right.
a differential there on how we do it. And certainly in our model, cash flow is a big difference.
Right.
You know, it's taken us this long to get comfortable of understanding, you know, the black box that CMS works within in order to create a business outside of Genesis. But we've gotten to the point of extreme comfort, extreme predictability, that we're able to do that now. But it will take a few cycles. So behavior will change because of money, and I think we both know that from our days of Medicare Advantage and how to change. You put money in the hands of the right providers, and things can change rather quickly. Our challenge is the fact that we're just giving out checks once a year, and you've got the ability to do it more frequently, but maybe you want to...
No, I think you guys have the advantage of predictability of fees because people know the fee schedules. They're submitting bills to Medicare, they're submitting Part A days, they're submitting Part B days. It's paid by Medicare, traditional fee-for-service Medicare through the MAC. There's some comfort level with that, and some providers like it, and they understand it. Our model is quite different because we are getting the premium. It isn't, let's reconcile a year from now. It's a different model. We get a check from CMS every month for every member, and that check could be $2,000, $2,500. It depends on how the person is coded. But we get that check, and we capitate the buildings. So they get a check from us every month for all their services. They don't bill Medicare. We are Medicare. Any services that Medicare would have normally paid for, we're paying for either through capitation or fee-for-service. And the bonuses are paid for on a contemporaneous basis. They're paid for quarterly, every 6 months, based on results, based on value-based outcomes, based on outcomes. So the advantage for us is there's cash flow, predictable, defined cash flow every month with the opportunity to earn bonuses. The advantage on the ACO side is they're predictable unit cost payments every month. And you know, one of the questions that over time we'll figure out is, does one incent the behavior differently than the other? I think it's a little too early to know, but is someone getting capped every month and getting bonuses if they earn it quarterly? Does that create a different incentive structure than getting paid fee-for-service all along and then bonus at the end? Obviously, Jason will give you his perspective, and I respect that, and we don't know. And ours is mine's a bit different. You know, coming from the managed care world, as we both did, our model is the managed care model, and that model is the ACO MSSP model. Both of them have succeeded. I think over time, and Jason we can debate it, the managed care model will continue to grow. MA will continue to grow. It's at 30-something%. It will continue to grow. And the reality, I think over time, these programs become closer and closer together.
Yeah, I mean, I don't think there's much to debate. If we had the ability, financial capability to provide distributions more often, a portion of what gets reconciled, we would. And that's actually the vision. And like you know, I try to treat this fee-for-service environment like a managed care plan as much as possible, but I definitely would not disagree that the faster you can put money in the hands of providers, the faster you're going to see change. And we see that even within Genesis, change happening when the money goes down to that facility level. And so you got the facility, you got the region, you got all the infrastructures getting rewarded for it. But we're doing, you know, what we can in a very unique situation. This program was not made for the long-term care environment. We are fitting a square peg in a round hole, but we're doing it with the same tenets of managed care to the extent that we can. We can't manage, you know, we can't have the alternative benefits. We can't truly manage utilization except to provide good care. And I'm okay with that. I know that I wasn't okay when we were making our numbers in the old days by denying services and ticking off our provider partners. So it puts us in a different, slightly disadvantaged position, but I think it's one that allows us to stay more closely aligned with the healthcare delivery system.
I think in our old worlds, there was a lot more denial. Here, it's not really, you don't see nearly the denials. You see change in treatment protocols. You see change in the way patients are treated. You see access to a different level of care than you've seen in the old world, because you see these patients every day. It's in a very controlled environment. The MA world, traditional MA world, is not a controlled environment. So the way you control it is by not authorizing things. The way you control it in this environment is by putting clinicians in place to manage the care, not deny the care. So the world, one of the things we started with, this world of managed care is quite different than traditional MA or managed Medicaid or managed HMO. It's just a different world. The benefits are different, the exposure is different. Medicare, whether you're in network or out of network, less of an issue with Jason, still pays 100% of Medicare. It's not a big differential. The differential is the access to clinical care and social support and stimulation for a population that otherwise is challenged given their age and their burden of illness that they have. It's a very different world than what you see even in your own benefits if you're in an HMO or in a PPO plan. It's just different. We don't spend our day denying care or denying referrals. That's just not what happens in this world. Right? Same thing for you.
But yeah, same thing. And I feel much better about that. I mean, certainly times have changed, but I feel much better about that, and I think our provider partners do too. And the last thing you want to do in this environment is start denying claims from hospitals who are providing you admissions. So again, I think these models are very similar, different financing platforms. I think we share a very, very synergistic perspective on how it's to perform in the market. To René's point earlier, just reiterated a few times, I'll do it again, value-based care is here to stay. I preach it at every conference that I go to. That if you think the same old is going to hold on for the next 3, 5, 10, 20 years, you're just fooling yourself. And this industry has done a lot of that. But I'm pleased about all the conversations that have been going on over the last, at least with my exposure, 5 or 6 years about iSNPs. I think that's provided a forum for creativity from the fee-for-service side that we've demonstrated, and it's created a level of creativity in I'll call the non-Optum market for providers and non-provider partners to get into the business. And I think it's all about containing care. The resident was put there for a reason, and that is to have a residence, to maintain care, to get better outcomes. They're eventually going to pass away. But I think we both feel like it's our job to make sure they're getting the best care possible in the right setting at the right time.
It's just doing the right thing. At the end of the day, it's just doing the right thing for the member, and sending a 90-year-old or an 89-year-old or a 95-year-old to the hospital, in many cases, is a death sentence. They're going to get some weird infection, nosocomial infection. Someone's going to make a mistake. Something's going to happen. And they're going to be confused. It's just not the right thing. If someone needs to go, they need to go. But if you can avoid any kind of excess care in a 90-plus-year-old, you're going to be a lot better off. They probably got to that age because they didn't go to doctors and they didn't do all these things. And don't ruin their record. They've made it this long because they've avoided unnecessary things. Let's not precipitate it and cause more problems than they had in the first place.
So René, we've got 10 minutes left. Are you okay opening it up to questions?
Sure.
Are there any questions from our audience about either one of our programs, or about how these programs work together? Yes, sir.
You just mentioned how they work together. You kind of started out talking about how these two fit in the same home, and it's really almost a collaborative relationship. Can you talk about which patients are a better fit for one or the other, and why?
Well, the reality is that, and Renee alluded to this, is that a resident has to choose to be in an iSNP. They're actually enrolling into a program. They're taking an affirmative action. In the ACO, those folks are not in an iSNP. They're fee-for-service patients. They may have made the decision, or the family made the decision not to be in a managed care plan for them, and their physician is participating with us. So, you know, again, talking about which patients belong where is not a conversation I feel comfortable with, because it's not the sicker go here and the less sick go there, and that whole concept of cherry picking really shouldn't exist out there, and I hope it doesn't exist out there. So it's really not from a clinical perspective, but it's more from just the pure election by the.
So I think there's two pieces. One is there is a benefit differential. The benefit structure is different in an iSNP than in an ACO. So there are going to be people who need those supplemental benefits. And generally, when you go into a building and they have the way you enroll people for an iSNP, there's a champion, identifies who those eligibles are, and identifies the plan. And for some people, it's more compatible than others. Some of it is because of benefits, because of other issues. And again, remember, the member knows they're in an iSNP. We have created, and hopefully can deliver, certain expectations to that member as to the value of being in an iSNP is. And so it's a bit different. The other thing, it's a different financial model. So I would suggest, and I think Jason will agree, in rural communities, the NPs are getting paid fee for service, so they can do lots of things. In a rural community, if we have a single building and there's 10 patients, we hire the nurse, the NP. It's a much more difficult, in the current model, it's a much more difficult financial model. So we need to evolve. We need to evolve into rural strategies that will be different. The strategy that works in Manhattan, or that works in Chicago, or that works in Tulsa, is not going to work in rural Oklahoma or rural Florida. So the creativity is different, the financials are different, the staffing is different. So there's differences, not because they're sicker or not sicker, but objectively there may be certain things that they want that a fee-for-service world doesn't provide to them. That clearly is to their benefit. And secondly, it's their knowledge of the participation and the expectations, because I would guess, some do, but many of them don't know they're even in an ACO.
No, I mean, they're required to get a member notification on an annual basis, but again, with this population, they don't know, and they can't elect to get out except to sign up for an iSNP or pass away.
But the NPs go see them, and they do similar things.
Right.
So there's a bit of a different, identification of what a typical member would be. Again, they can go either way, but there's differences and advantages and disadvantages economically, socially, that may or may not meet someone's needs. And there's a difference from our perspective in terms of financial model that makes sense in a given building.
Yes, sir. Yeah, that's a really good question. Unlike an iSNP where people enroll, making that affirmative action, the way we're getting membership is through a concept called attribution, which requires at least one physician visit a year. So we employ or we use nurse practitioners, it's that physician visit that is creating that attribution. So we need the physician. I'm of the strong belief that you need the facility as well. Technically, you don't. But if you're really looking to change care and you want everyone rowing in the same direction, you're missing a huge opportunity by not aligning yourself with the facility. Because the docs or the NPs, they can't do it alone. When you look at root causes of why people are sent out, to Renee's point, A lot of it's just easier for the facility at times to send a patient out, not take care of them. So yeah, technically, I could just go with physicians. Programmatically, philosophically, it's a joint effort, and that we'll continue to operate like that. Yes, sir. Oh, it's you, Ira. I didn't mean to call you sir. That's why I apologize.
No. Our aspiration is to be second or third largest by the end of the year. At 2,000 lives, we're probably 7, 8, 9, something like that. But we've been around for only a year, so I'm okay with that. So we're a bit unique from an iSNP perspective, other than Optum, which is obviously the largest multiples. There are not very many multi-state iSNPs. I believe that we are the probably biggest in terms of number of states, or close to the biggest, and by next year we'll be in 7 or 8 states. I think the only one who'll be bigger than us state-wise is United, Optum. Membership-wise, obviously, they're much, much bigger than we are. So the advantage that we have, as opposed to these single-state iSNPs, or there are some homes that are building their own, is we have scale. Our goal is to have scale. And so with scale, on a national basis, we can decrease administrative costs at the HMO level. At the local level, for clinical things, that's sort of local. But we believe that over time, each state that participates with us and the owners in that state, generally that are investors in us, get the benefit of national scale as opposed to local scale. And that's quite relevant. So the fact that in 14 months, we've grown to almost 2,000 members with an expectation to be more than double that by the end of the year. We're growing quite rapidly. Just to give you a sense, we went live, we were in the end of December, we were in about 15, 16 buildings in 2 states. At the end of January, we will be in close to 70 buildings. So in 5 states. So we're growing very rapidly, and I think the appeal is, it's quite a different model than most of the other iSNPs out there, because it really is meant to be a provider-sponsored iSNP, where the owners own half the plan and therefore see every number and totally transparent. That's pretty unique, and I think it's appealing. We're a single product plan, so multi-product plans have certain advantages over us, but I think over time that's changing also. And that people are looking for best in class or what's best for them. And as a result, where a year ago nobody knew how to spell longevity, a year later we're getting inbound calls from probably 10, 12 different states right now. So that scale, national scale, will make a difference.
Any other questions? Okay, well, thank you for being such a patient audience.
Thank you.
Thanks, René.